Welcome. Thank you for coming to this session this morning. What I have been asked to do today is to kind of drill down a little bit. We've heard this morning about a lot of the factors and things that surround infant mortality and poor birth outcomes. And today in this session, we're going to drill down a little bit and look at one specific aspect of infant mortality and poor birth outcomes, substance use during pregnancy. And so what I want to share with you today are two things. Talk a bit about the prevalence and the dangers of pregnancy substance use. So we'll go through kind of the different substances we know that women use during pregnancy, what some of the outcomes are related to those. And then I want to spend the second half of the talk talking a little bit about intervention approaches. So my focus will be very practical, hands-on. You will walk away from here with some things that you can instantly use in practice or share with staff that work for you, things that they can implement in working with pregnant women who may use substances. All right, so just to give you an overview of pregnancy substance use in Tennessee, we heard an amazing statistic this morning that 1 in 3 women in western Kentucky were testing positive for an illicit substance. That may be very eye-opening to you, but there are places in Tennessee where that is also the case. Talk to you first at the top about smoking. Okay, tobacco is a drug, the nicotine in particular. And we know that in the United States, about 12% of women smoke during pregnancy. The rate is much higher in Tennessee, as you can imagine, at about 17-18%. And I work on the east side of the state, so in Appalachia, Tennessee, we see rates over 30% in some of our counties. So we have a very high rate of smoking over in that side of the state. And there are certainly pockets throughout the state where we do have some very high rates as well. Nationally, we know that about 20% of pregnant women consume alcohol. Those are national prevalence data. The rate in Tennessee is similar. We do see that Tennessee is about in line with the national average, but we do again see pockets. And those pockets, instead of the rural areas where we see the smoking, is the urban areas. So we see a lot higher rates of alcohol consumption in urban areas. All right, in terms of illicit drug use during pregnancy, estimates vary widely. We don't have any really good kind of epidemiological data on illicit drug use during pregnancy, but we do know from the data that we have managed to gather that Tennessee is about on par nationally for the use of most substances, with a couple of exceptions. We do have a high rate of methamphetamine use in the state that is higher than national averages, but most other drugs besides meth and abuse of prescription narcotics, that's another thing that we see high rates of. All right, when a woman is using substances during pregnancy, what we often find is that substance use tends to co-occur. So a woman who is using one substance is much more likely to use another substance. And this is true for tobacco and alcohol as well as other harder drugs. So what that means is many things. First of all, it obviously complicates the pregnancy exponentially. As you have more drugs, you have more complications. But it also makes intervention efforts very difficult because you're now trying to target multiple things that are addictive, that are hard for women to quit, and it complicates a lot of things. So we do know that things do co-occur. We also have to be very careful when we're talking about pregnancy substance use and interventions that we don't type women. It's very easy when a woman walks into the health department, when she walks into a clinic, that you get this idea, I bet that woman's using drugs. Okay? You have intuition and you may be right. Okay? You've worked with a lot of women. And you do often are able to pick that up. But there are a lot of women that you wouldn't suspect that are using substances. And so it's very important that you not get into a mindset of, these are substance-using women and this woman doesn't look like a substance user, so I'm not going to ask her, or I'm not going to probe, or I'm not going to do testing. Because we know that while their substance use is more common in certain groups of women, we know that lower socioeconomic groups, women living in poverty, lower education, women with other risk factors are statistically more likely to use substances. Substances can occur at any level, any socio-demographic level, any risk factor, no risk factor at all. That might be their only one. So we have to be really careful. We do know that there are some racial differences and socioeconomic differences that we can kind of use to, I would say, maybe highlight areas for intervention, but we have to be careful not to target certain women or certain groups of women. For example, we know that white women are more likely to smoke cigarettes during pregnancy. African American women more likely to use alcohol. Okay, that's just statistically speaking, but it's certainly not universal. And as I mentioned, the socioeconomic risk. Another interesting thing is that women with fewer risk factors are more likely to falsely deny use. Okay, no surprise there probably. We looked at some data from Northeast Tennessee and found that women, white upper class women, were 3 times more likely to deny smoking than women at lower socioeconomic levels. So just because you then ask doesn't mean you're getting necessarily an honest answer, especially at higher socioeconomic levels. So it's important to recognize those factors when you start looking at intervention. All right, I have a couple slides here that may or may not be of interest to you, but I thought I would just put them up briefly to give you an idea of how substances affect the fetus. And I'll talk about what some of the effects are. But often people are interested in the mechanism. So how does smoking a cigarette then lead to fetal problems? Or how does using a particular drug, drinking alcohol? And here's an example here for smoking. But what we see is that oxygen deprivation seems to really be the key for a lot of the substances. So the baby's being deprived of oxygen, and that affects all sorts of aspects of development. We also know that there are neuroendocrine development is affected. That we see differences in how neurotransmitters work as the baby develops, and all of that will come from this substance exposure. All right, so here's some examples for alcohol and for other drugs besides tobacco. And we see that, again, oxygenation, neurotransmitters tend to be the key. And a lot of this we still don't know yet. You know, we know that there are certain effects, which I'll go through, but we don't necessarily know all the mechanisms involved. All right, so what are some of these effects? The effects of pregnancy illicit drug use in particular, so here we're talking about things such as cocaine, heroin, methamphetamine. And we know that babies born to women who use these substances while they're pregnant are much more likely to have poor birth outcomes. They're more likely to be preterm. They're more likely to be low birth weight. Depending on how much a woman uses, we could see double or even triple the risk. Okay? We also see that these babies are at risk for neonatal abstinence syndrome. Okay, how many people have ever dealt with a baby with neonatal abstinence syndrome? Quite a few. Okay, you don't forget that. These babies are very unique. They have a very specific set of problems when they're born, having to do mostly with reactivity. They're very fussy. They cry quite a bit. They shake, they tremble. There's a whole host of things, and they are very much medically at risk. Most babies with neonatal abstinence syndrome will end up in the NICU. We've developed over the last decade or so quite a few very successful treatments for babies with neonatal abstinence syndrome. Knoxville Children's Hospital over on the east side is one that has really been leading the way regionally in terms of work that's being done, and it's being done everywhere now. But we have seen that in terms of the long-term effects, so we have a baby who either has neonatal abstinence syndrome, has low birth weight, is preterm, or perhaps not. But a baby born to a woman using substances has an increased likelihood of a whole host of health problems. So we see later on they have delayed growth and development. They might be shorter than their peers, not catching up in height and in weight. And evidence of long-term effects for behavior problems, and these babies are also, as they grow up to be children and young adults, more likely to use substances themselves. Not only perhaps because of the environmental modeling, as you might expect, but also because there seems to be some aspect of fetal development where they're being primed, so they're just much more susceptible to then end up with an addiction themselves. All right, so what about marijuana? Marijuana is obviously also an illicit drug, but you notice I didn't have it on the last slide. Interestingly, prenatal marijuana in many ways does not appear to carry the same risk as a lot of the other substances. Now, that's not to say that it's okay to use marijuana during pregnancy, and I'm not saying that at all. But what we have seen is that there's not consistent evidence for major long-term health and growth effects. I know there are some studies that have found effects, other studies that have not found effects, so certainly the evidence is inconsistent. We do know that when we start looking long-term at more subtle developmental effects, so perhaps some alterations in cognitive development, executive functioning, how kids process information, attention problems, we do see slightly increased rates in kids with prenatal marijuana exposure. But the interesting thing is it's often very hard to tease apart the effects because women who smoke marijuana, about 80% of them also smoke cigarettes. Okay, at least that's the data that we found in Tennessee. So that you have all of these marijuana users who are also smoking cigarettes, it's very hard to tease apart which substance is causing the effect. And we know a lot more about the effects of tobacco, and so often we attribute what we end up seeing to tobacco rather than marijuana. All right, so what about prescription drug abuse? This has become increasingly common here as well as nationally. In particular, we see that women are abusing narcotics and sedatives in particular. Those are the two that we often see during pregnancy. We don't have a lot of long-term data, unfortunately. We do know in terms of the birth effects that we have decreased birth weight, we have increased rates of preterm delivery. We do see neonatal abstinence syndrome with the babies that are exposed to narcotics prenatally. But what we don't know is what are the long-term developmental effects. This is a fairly new problem being studied. There is a fair amount of evidence that is suggesting that the effects that are there are what we would see to chemically similar illicit drugs. Okay, so maybe a baby that is exposed to oxycodone may present very much like a baby who was cocaine exposed, for example. Okay, so things that are chemically similar. So we're making some inferences now in terms of long-term effects, but we really don't know yet. So a lot of those studies are still ongoing. All right, alcohol. Most of you have probably heard of fetal alcohol syndrome, or FAS. FAS is the most extreme outcome of a child with prenatal exposure, where you get this classic facial dysmorphology on our baby here. We see growth restriction and pretty significant cognitive impairment. Most people with fetal alcohol syndrome have at least mild mental retardation, have a lot of problems functioning independently. But even at much lower levels, as few as 5 drinks a week, we do see that babies with this exposure are more likely to be low birth weight, are more likely to be born preterm. And then they have delayed growth and long-term cognitive problems. There doesn't seem to be a catch-up for these children that are exposed long-term. And the one biggest culprit most of the recent studies have shown is binge drinking. So a woman may only drink once a month while she's pregnant, but when she goes out and drinks, she drinks 5 drinks at a time. Okay, that's the type of exposure that we tend to see as most harmful to children long-term. Now, there was a study that came out over the summer, and I don't know if any of you heard about it. It got a lot of popular press coverage. It was a study that was published in the British Journal of Obstetrics and Gynecology back in June. And they were looking very specifically at one outcome at age 5, what we call executive functioning, which is an aspect of cognitive development. And they found that kids at age 5 who had prenatal alcohol exposure at what we call moderate or lower levels, so anywhere from about 8 drinks a week or less, didn't have any effects on executive function. And this was picked up. Did anybody catch the story over the summer? A few people are smiling and shaking their heads. This was picked up in the popular press as evidence that it's okay to drink during pregnancy, at least at low levels, which I had heard the study came out and I had read it and I thought, okay, we found one outcome that's not necessarily related to alcohol exposure at low levels. And about a week later, because before I did tobacco research, I did alcohol research and have published in that field quite a bit, I got a call from a reporter asking me to comment on the story. She said, now, we're going with a story that says that it's okay for women to drink at low levels during pregnancy. Do you have any comment? I said, well, yeah, I have a lot of comments. How much time do you have? And so I found it very interesting that the interpretation from this one study done in Denmark was being interpreted as it's okay to drink during pregnancy. And you may hear that from some people. And keep in mind this, they were looking at one outcome. It was a fairly small sample. They did not look at binge drinking in particular. And they found that the kids exposed to 5 drinks or fewer a week, there were no effects on executive function. So the authors were very clear that this does not mean it's okay to drink during pregnancy. The lack of finding harm does not mean it's okay, but it did get misinterpreted, so I wanted to bring that up. All right, so what about pregnancy tobacco use, which is obviously our most commonly misused substance during pregnancy in the state of Tennessee? We don't always think of tobacco when we talk about drug use during pregnancy. And I think this is unfortunate for many reasons. First of all, because it's so common, and second, because we know that tobacco has the effects that all of these other substances do. And given how common it is, obviously this has even a bigger public health impact than some of the other substances. I show you this picture, and this would have worked for any of our substances, but I'm putting it up here for tobacco. So you can see that when a woman uses a substance during pregnancy, we're talking about a whole host of effects that it can have on the child from gestation all the way through to adulthood is the point there. All right, so what are some of the effects of prenatal tobacco exposure? Now, we have very definitively found a causal link between smoking during pregnancy and a lot of birth outcomes, and it's due mostly to intrauterine growth restriction rather than babies being born preterm. And we see anywhere from 250 gram deficits in birth weight to babies exposed to maybe a half a pack of cigarettes a day or fewer. Exposure at higher levels, say a pack a day, we see 400 grams or more. Okay, so almost a pound in birth weight of a decrease we see from babies who are exposed to a high level of smoking prenatally. High rates of spontaneous abortion, miscarriage, stillbirth, preterm delivery, as you can imagine. And we see that these decreased growth deficits continue. So a child who is born small because of prenatal substance exposure tends not to catch up. Study that was released a few years back looked at kids at age 7, pretty large-scale study, and found that those kids were still an inch shorter at age 7 that were exposed to a pack or more a day during pregnancy or during their fetal development. Okay, some of the health problems that we know about, many of them focus on the respiratory system, as you can imagine. So that kids who had prenatal exposure to tobacco, increased rates of sudden infant death syndrome, allergies, asthma, respiratory and ear infections. And this is after controlling for postnatal smoke exposure. Okay, so as you can imagine, a child who is exposed prenatally to tobacco is probably coming home to a house where one or more people smoke. Okay? Even if you remove that effect, either statistically or you find babies whose mothers quit after they deliver, we still see these effects. So it's not all the postnatal smoke exposure, it's effects prenatally. All right, so I wanted to show you this. Most of you being in the field, you are probably pretty aware at the cost associated with a premature baby. But I think it's important to note because this is the one effect that we talk about very often when we talk about babies that are exposed to drugs prenatally. Get caught up on my notes here. All right, so one of the things that I have struggled with when working in the community and doing interventions is really talking about what it means to be born preterm in terms of immediate consequences and long-term outcomes. Now, obviously, the financial costs are clear and the impact that has on strained healthcare resources. But one of the things that was interesting to me when I went out into the communities and was working with groups of teens who were pregnant was that we were really getting away from giving the message of if you smoke and use drugs during pregnancy, you're going to have a smaller baby and it's going to be born earlier. Okay, and some of you are smiling, you know what I mean. This isn't necessarily seen as a negative for some of the moms that you will work with. And so it's really important to stress all of the negative things that go with that preterm birth or that low birth weight birth. And one of the nurses that I worked with in West Virginia probably said it best. She said, I tell all my moms that I work with that smaller baby at birth equals smaller brain. And really pound home the point that you don't want that small baby. Even though that might mean you don't get as big, the delivery comes early, there are so many consequences, and it's very important to talk about that. Don't just say, well, if you keep smoking, you're going to deliver early. You need to follow up that message so that that's not necessarily viewed as a positive. All right, in terms of longer-term effects of tobacco exposure, again, because this is one of the more commonly used substances we know quite a lot about, all of the effects. We see decreases in IQ of 10 points or more when kids get into school that have had high levels of tobacco exposure prenatally. Substantially increased rates of attention problems, almost double the rates of ADHD diagnosis. Depression, anxiety, conduct problems. So you can see there's a whole host of things that have been studied for 20, 30 years in relation to prenatal smoke exposure. All right, couple final notes about smoke exposure, just because this has been my recent area of expertise. We talk a lot about secondhand smoke and thirdhand smoke. With a lot of other substances, if the other people in the home drink when a woman is pregnant or they're using non-inhaled substances, the effect really doesn't go to the mother. But with smoking, we do. And so we see the effects of secondhand smoke, what we've most recently called thirdhand smoke, which is the residue that gets on things from the smoking. And both of these are harmful to the developing fetus and, of course, to children living in that environment. And we found that women with high levels of secondhand smoke exposure, their babies have outcomes similar to women who smoke themselves during pregnancy. So it's really important when you address smoking with women that you also talk about the smoke in their environment. All right, the amount and timing of cigarette exposure are important, and other substances as well. There doesn't seem to be a real threshold effect with any substance. So basically, the more that you use of tobacco, of drugs, of alcohol, the greater the effect is going to be. And we've not identified a safe level of any substance during pregnancy. So, for a woman to say, oh, well, I only use marijuana, every other Sunday, or whatever it is, we still don't know that that's safe. And so it's really important to stress an abstinence message with women. But that said, we do know that the more you use, the greater the effects there are. And particularly in dealing with tobacco users, a woman who's smoking a pack and a half a day comes to you, and you're not going to expect her to tomorrow all of a sudden have quit. And so knowing that as you smoke more, the effects are greater, we do work with women to get them to cut down. Obviously, the eventual goal is to get them to quit, but letting them know that even if you can cut down, you will see effects. You will see positive effects for your baby. And it's that way for alcohol or any other substance. We also know that the timing is important, and we hear very often in this field that the first trimester is very important in terms of development, and it is. When we talk about alcohol, we see the greatest effects for alcohol in the first trimester. When we talk about a lot of the illicit drugs, the greatest effects are in the first trimester. Smoking, not necessarily. We actually see that the effects of prenatal exposure to nicotine and tobacco are greatest in the third trimester. It has to do with the mechanism of the effect and how things are happening prenatally. But if you can get a woman to quit smoking by the middle of her pregnancy and definitely by the end of the second trimester, she can have outcomes close to a woman who didn't smoke at all during pregnancy. So there is a very clear window of opportunity during pregnancy where you can make a difference if you can get them smoke-free by the third trimester. So I think that's very important to know when it comes to doing interventions. All right, so the other thing I've been challenged with has been getting providers, getting people who work with pregnant women to recognize that it's important to get women to quit all substances. I have gone into prenatal practices and talked to providers about trying to get them to get women to quit smoking, since that's our major problem in Northeast Tennessee. And I'm often met with the idea that, well, I have a lot of women using marijuana and a lot of women drinking. I really need to tackle those problems first, and then we'll worry about smoking. Okay, well, they do need to tackle those problems. I'm certainly saying they shouldn't. But tobacco really also needs to be a focus, because as I just showed you, the effects are just as severe. And in fact, some of the studies that have looked at the relative effects of the substances have found that smoking during pregnancy, in terms of effects on birth weight in particular, has almost double the impact. And I've got a slide to show you the numbers. So it's important to recognize that you need to include tobacco as part of a substance use campaign with women. And I won't go into detail here, but this is data that we got from Northeast Tennessee, and this was doing meconium testing with the babies. So these were people who had confirmed exposure, and the reduction in birth weight attributed to different substances. And hard illicit drug use, 163 grams. Smoking independently was over 300 grams. Okay, so the effect on birth weight, and this is only one outcome, remember, was greater for smoking than any other substance that these women used. And obviously, the combination effect was the largest. Okay, so very important. All substances are key. All right, another issue that has come up is we've worked with providers, worked with health departments to get them to address substance use during pregnancy, is can it be harmful for a woman to quit using a substance during pregnancy? We have actually had women come tell us that they have heard from a healthcare professional that they should not quit smoking during pregnancy because it might be too harmful to the fetus, that it's too stressful on the body, and they shouldn't quit. Well, you wonder how much of that might have been their selective hearing of what they wanted to hear. But I actually found one provider who confirmed that he was telling people this. And obviously quitting is stressful. We know that withdrawal is difficult. But both ACOG and the American Academy of Pediatrics say that a woman should never be told not to quit smoking during pregnancy. The benefits of quitting clearly outweigh any dangers that could occur. Now, this is pretty much the case for other drugs as well. Certainly, casual use of alcohol and other substances, women should be recommended to quit, and they can do this on their own. Substances, opiates in particular, we need to medically manage them quitting. So it's very important there. And for heavy use of any substance, we need to make sure that they are medically managed. If a woman is severely alcohol dependent, withdrawal can be very difficult. And so we need to make sure that the fetus is protected, and that is done medically supervised. But in terms of casual use of most substances, and tobacco in particular, there's definitely no harm from a woman going ahead and quitting. All right, I don't know how many of you have seen this before. This has kind of made the rounds a little bit. But this is a woman, this is from the Roanoke paper, who was concerned about the effects of the jackhammers from the construction on her unborn baby. Look at what's in her right hand. Cigarette. This was actually published in the Roanoke paper. And I put this up here kind of to give you a sense of how we sometimes get a little bit distracted from the true things we need to focus on prenatally. What we think might be the biggest danger of all might really not be, and so it's very important to look at the whole environment that a woman has and address all of her needs and all of the things that might complicate her pregnancy, might lead to a poor birth outcome, might lead to the child dying in the first year of life. So anyway, I thought you might enjoy seeing this. All right, so when we start intervening with pregnant women, the first question that comes to mind is, does it work? Because a lot of providers will tell you, I talk to women about their substance use, we test, we go through all of this, and nobody quits. I feel like I'm banging my head against the wall. Does it really work? Well, we do know that it is a long process. You're not going to be successful 100% of the time. But even simple efforts, simple advice to quit, encouragement, even in a non-structured way, about 10% of women will quit smoking, maybe 20% or so will stop using other drugs. Okay? And that's pretty minimal effort on the part of a healthcare provider. We see women who use the quit line, pregnant women who use the quit line, we have 10% plus that will end up quitting. The 5As, which is what I'm going to talk about today, which is a more structured model for intervention, we see quit rates of 20% or more for smoking, and when it's used with women who use other substances, up to almost half of them will quit when you use a 5As model consistently. We know that if they can quit smoking during pregnancy, we have improved birth outcomes, especially a reduction in preterm delivery, and even cutting down, we see substantial gains. So when you look overall at can an intervention be useful, both in terms of will women quit and does it improve birth outcomes, the answer is yes. But if you're expecting that every woman that you work with will quit, you will be disappointed. Okay, so you do have to realize what your target goal should be and what's realistic and when you should feel successful. If you can get one woman to quit, okay, that's a success. But the efforts have to be regular and consistent to have an impact. So you need to ask every woman who comes in about substance use, or test every woman who comes in for substances, and each time she's there, talk about it, bring it up, address it. All right, work we have done in Northeast Tennessee, because we had a lot of women who were not quitting, and we were trying to find out what they wanted in terms of an intervention, and this was obviously as we were trying to design our intervention several years ago. There was a real strong preference for individual discussions. I had come from the north in Detroit, where we had done a lot of group work with women, and the centering pregnancy model is a really good example. But for women substance users in Tennessee, that model has not worked very well. We set up all sorts of support groups and quit groups. Nobody showed up. Okay? And we started asking women about this. I said, I'm really not comfortable talking about this in front of a group of people. I'm willing to talk to my provider, but I don't want to do this as a group. So individual sessions was where we needed to go. We also have women telling us they knew the dangers of pregnancy, smoking, or drug use. It's not that they were unaware for the most part. They might not have known how severe it was or how substantial the impact was, but most of them would tell you, I know that this is something that is unhealthy for my baby, but they were still unable or unwilling to quit. And the main thing that they cited was that their providers talked to them about smoking or substance use, but the discussions didn't go far enough. So, he or she told me to quit, but then what? I left the office and I didn't really know what to do. So what I want to talk about now is to kind of give you those tools, some of those things that you can share with women to maybe help move them to the next step. Okay, here's just an example from our data in Northeast Tennessee in terms of the success rates for women who reduced and who quit smoking. We had a 28% quit rate in our program, and that was having health educators in practices. But as you can see here, those who reduced smoking had some improvements in birth outcomes, and those who